Hello, my name is Dr. Caroline Corey. I am a doctorate of nursing practice graduate from the University of Cincinnati, and this is my doctoral research project, Heart Failure Education, Evaluating Telemetry Nurses' Knowledge and Confidence. My team members were my doctoral chair, Dr. Kathleen Ballman, as well as Implementation Site Unit Manager, Regina Hembry. So let's go over some background information before we dive into how I performed this intervention, as well as what the results were. So heart failure has become one of the most problematic diagnoses in the U.S. healthcare agenda. In 2016, Arundel found 1 in 4 patients with heart failure were readmitted within 30 days of discharge. So there are many consequences to having this occur. So there are consequences to health for the patients. So 30-day readmissions are correlated with higher risk of morbidity and mortality. People can have lifestyle constraints related to the morbidity, mortality, and the heart failure. And there is financial burden to patients, their families, as well as to hospital systems. So as far as hospital systems, there are quite a bit of financial repercussions. So Center of Medicare and Medicaid Services enforced penalties based on readmission of 6 diagnoses. Heart failure happens to be one of them. And in 2017, there was about $528 million worth of penalties affecting 78% of US hospitals. So that's a pretty significant amount of money and portion of US hospitals being affected by these penalties. I also wanted to evaluate a bit of nursing staff involvement since I will be focusing on the role of the nursing staff. So Dr. Nancy Albert is a well-known researcher for heart failure as well as nursing involvement, and she found that nurses' comfort was significantly associated with how frequently the education was delivered to patients. So it's like that mentality, if you don't use it, you lose it. So the more we can refresh, the more we can provide education or have resources to help provide education, the better our nurses will be able to provide education and it being effective education for these patients. So the purpose behind this project was to investigate more into nursing knowledge and their perceived confidence regarding education of heart failure patients. And I did this through an online education module. So I wanted to also throughout enhance knowledge of nurses for heart failure throughout this intervention. So in building this intervention, I utilized the Plan, Do, Study, Act framework. Basically, this gave me a good backbone to building the project, as well as I like the way that the framework is built. It's a cyclical model, because when we do process improvement, quality improvement, it is a continuous cycle. There is no true end point, because there's always things that we could accomplish or do better. And it is a continuous model. So in the plan portion, I perform needs assessments of the implementation site, the unit in question, and perform some literature reviews. Based on some of the information I gathered, I also collaborated with one of the institution's cardiologists, my doctoral chair, Dr. Bronwyn, and the unit manager, Regina, to help shape the investigation. So in the do portion, I had implemented the intervention utilizing the education database that the institution uses. And then for the study portion, data was de-identified by a third party, and I interpreted it, identified areas that had improvement and areas needing improvement, and overall found the intervention to be effective, which we'll go over later. And in the ACT portion, basically based off feedback and based off scoring, I did modify the intervention based on length of time and their feedback. And my plan is to release the education module for annual education onboarding for the unit as requested by unit management. Excuse me. And in performing this education intervention, I was able to provide resources to unit staff and assist them in perpetuating their quality improvement and education on their unit. So the methods portion, this is a simplified breakdown of it. From the purpose, I branch into the methods. So I already know that I wanted to evaluate nursing knowledge and competence of heart failure. And from there, I had to choose my setting. So I chose a satellite hospital in a suburban community. I wanted it to be an inpatient unit. So I chose a single telemetry unit where majority of their patients happened to be cardiac patients. And then evaluated what resources will I need. And then I utilized the Preventative Cardiovascular Nurses Association, which I am a part of, and they had free education handouts for patients for members, which is how I built my education module. I also got involved with unit leadership, who got me in touch with the health IT education coordinator, who helped me basically transition my education from PowerPoint into their online database. She also de-identified my data for me and sent that over. I then wanted to target my participants. So who did I want to take this education? So who did most of the education? The registered nurses. So our institution does not use LPNs. So I just basically targeted the registered nurses. In the recruitment process, I had put up flyers as well as attended huddle meetings of both day shift and night shift, and then had email blasts with the help of unit management. So this is a little more in-depth progression of my project. So it started out with formulating my pre and post-test surveys, which I used the Preventative Cardiovascular Nurses Association, as well as the Advanced Heart Failure Clinical Competency Survey by Goodland et al. So from there, I basically wanted to gather qualitative data based on narrative and feedback that participants had, as well as quantitative data, which is your true or false, multiple choice, select all that apply questions. Once I had the surveys built, I developed the education module, basically again using PCNA, UpToDate, Medscape, and other educational academic resources through PowerPoint. And I focused on basic pathophysiology, patient self-care, their diets, basic medication, classes, and what to really look at or teach for. Different advanced treatment options, very basic, as well as symptom management to try to help keep patients at home instead of readmitted. I then did my doctoral proposal and gained IRB approval and was deemed non-human subject research. From there, I worked with the hospital IT education coordinator and unit management, like again, to convert my intervention from PowerPoint onto their My Knowledge education database platform, as well as confirming I had approval with unit management to implement and to have her assistance with participant outreach. Once all the ducks were in a row, I made the education available for approximately 10 weeks for the participants. And then after that 10 weeks, the module was closed. And 3 weeks later, I had released a knowledge retention survey, which had matched the other pre-post test surveys. And I made that available for 2 weeks to kind of gather more information, see how effective the education was and how much did participants actually retain. And then after that, I had my de-identified data and I performed t-tests using Dr. Lambert, who is a statistics professor at University of Cincinnati. He had created a tool, so I used that as well as Microsoft Excel. So let's move on to results. This is the knowledge base outcome. So this is my pre-post test questions. So out of 49 nurses, I had 39 that participated. So the original average of the pretest is 69%. The passing rate is 80%. So keep that in mind. So after the pretest, participants did the education intervention, and then immediately after performed a post-test. So out of those 39 nurses, the average increased to 83%, which was statistically significant. And then after the close of the original intervention, I had 3 weeks later released the knowledge retention survey, and 20 of the original 39 participants had performed the test. There were other participants who didn't originally perform the initial surveys. They were not counted towards this. So out of the 20, we had about a 78% average, which was still very good. It was 2% off the passing rate of 80%. And the post-test was based off of first-time pass rate. So this is not taking the highest of multiple attempts. So first-time pass rate average was 83%, which was wonderful. And then knowledge retention test wasn't very far off and still statistically significant. So I'm very happy with how that turned out. There was about a 14% improvement in the initial post-test compared to the pre-test, which is fantastic. And then a 9% increase compared to the pre-test for the knowledge retention test. So the more you use it, the more that you retain, which is one of the associations that I am creating, as well as association of the more you know or understand, the increased knowledge also increases your perceived confidence with the education, which I will go through right now. So I had created 6 questions based on perceived confidence. This was a self-assessment that went along with the knowledge-based questions in the pre and post-test surveys. So confidence level 1 is the lowest level of confidence, and then confidence level 5 is the highest level of confidence. So you see, we have about a middle range for the pre-test, a lot of 3 and 4 level confidence, so moderate to strong level of confidence, with quite a few people reporting low levels of confidence. And then we merge into or segue into the post-test, which is more of a stronger levels of confidence, more confidence level 4 and 5. So I think there was a correlation with increased knowledge came increased confidence. I also did a Cronbach Alpha test on my perceived confidence assessment survey, just to kind of strengthen the data, and it had an acceptable internal validity. So that helps. All right, so moving on to the discussion portion. The frequently missed topics included where and when to seek help based on symptoms, understanding components of functional status, and dietary considerations, mainly salt-containing foods. Outcomes of the confidence assessment and understanding patient education both improved from pre to post, which is wonderful. It was a successful project. Unfortunately, there were some limitations that I did incur, mainly environmental factors. There were demand of the unit. Many of the participants more than likely took the education module while they were at work on shift. So they would have to pause, come back throughout the module. So there were quite a few interruptions because they were doing their job. So totally understandable. Also, there was the coronavirus, and that led to an inability to control the environment. So originally this intervention was going to be an in-person class where I could have better control of the environment, ensure people could worked independently, did not use any outside resources, look anything up on their phones or computers. But because of coronavirus, social distancing, I converted the education to being an online module. So to try to avoid these limitations would be to try having the education in person, and then also decreasing the length of time needed to complete the education module. So it would be a little easier to try to control your environment as far as how much time you need based on having a schedule. A little easier to control than just on a computer. So my recommendations based on what I found for this education should be an appropriate reading level based on other research. For Americans, reading level should be 8th grade or lower, and it needs to be tailored to individuals based on cultures, lifestyle practices. The more we can make this individualized, the better it might work for people. You know, there's not one size that truly fits all. Our education must be short, it must be simple and tactile. This way, it could be a little more of an engaged dynamic between patient and educator or provider. Also helps building on their autonomy. And then improvements in education and communication comes improved patient outcomes. So again, that education component, having that active dynamic in education between patient, provider, and providers themselves can have improved patient outcomes. I have included the resources I have used to build this education intervention and this project. I hope you enjoyed and have a great day.